Today's show is sponsored by strawberry.me. Do you ever feel like you're doing everything you're supposed to do, but you're still not totally clear on where you're headed? For a lot of nurses and nursing students, life can feel like a non-stop cycle of shifts, school, and responsibilities, with very little space to pause and think. But here's the thing. Success and fulfillment are built with clarity, with intention, and with follow-through. And many people get there with help. Coaching gives you a place to talk things through, whether you're feeling burned out, trying to set better boundaries, deciding what your next chapter looks like, or just wanting to feel more confident in the choices you're making. That's where strawberry.me personal coaching fits in. Working with a coach gives you clarity, strategy, and accountability, so you can sort through what matters, identify what's been keeping you stuck, and take meaningful steps forward. When your thoughts feel organized and your decisions feel intentional, everything gets lighter. Working with a coach has helped me define my goals, focus on what's most important, and absolutely skyrocket my productivity. Go to strawberry.me/nursemo and get 50% off your first coaching session. That's strawberry.me/nursemo. Get coaching for your career and your life. It takes heart to build bodies that break records. Over the last 6 years, a team of incredible healthcare professionals did what most people thought was impossible. They rebuilt the body of legendary Olympian Lindsey Vonn after a series of devastating injuries forced her into early retirement. Now she's headed to the 2026 Winter Games, ready to break records once again. This February in Milan, Lindsey's team and the entire USA medical team will be wearing FIGS. You can rock their official uniform too. The new Team USA collection from FIGS is engineered with Fiber X, the most durable fabric yet. Fiber X is the new gold standard for high-performance scrubwear. It's lightweight, breathable, and ultra-resilient. And of course, the styles come in red, white, and blue. Check out the limited edition Team USA collection and get 15% off your first order at wearfigs.com with code FIGSRX. That's wearfigs.com, code FIGSRX. Well, hello there. I'm Nurse Mo, and welcome to Mo's Monday Minute, a shorty episode of the Straight A Nursing podcast where I share a quick tip you can start using to improve your practice or habits right away. For more in-depth topics, check out the episodes that I release on Thursdays. Today, we're taking a quick little trip over into electrolytes land, talking about hypocalcemia and some common reasons that you could see a low calcium level or hypocalcemia in your patients. And the reason that we care about hypocalcemia is that when the calcium level is really low, the patient can have some pretty serious complications like seizures, really dangerous arrhythmias, and laryngospasm, which can close the airway. So we definitely want to be keeping an eye on calcium levels in our at-risk patients. So what are some common reasons for a low calcium level? One would be a patient who's had a thyroidectomy or even some kind of neck surgery. And this can be because the parathyroid gland is damaged in that procedure, and now we have low or even no parathyroid hormone. And when I say damaged, I mean maybe partially removed as part of that surgery or even completely removed as part of that surgery. So when we have less parathyroid hormone, we have less calcium being pulled into the bloodstream and floating around and showing up on your blood panel. So if you have a patient post-thyroidectomy who has tingling, which is one of those very common signs of a low calcium level, you're going to take that very seriously. And that risk is most likely to happen pretty early on after the surgery. Like within that first 24 hours, the calcium level can drop pretty significantly. So that's why calcium levels are checked on patients after thyroid surgery, like maybe the next morning after their thyroid surgery, or maybe, a certain number of hours after their surgery. Also, this risk can extend for a few days, maybe like up to 1, 2, or 3 days. This is a pretty common time for symptomatic hypocalcemia to show up, as the body is adjusting, and that parathyroid function may either be temporarily impaired because of some injury, or even just if that parathyroid hormone was really damaged or partially removed, they're going to be having their low calcium levels. So, a lot of times, sometimes these patients end up having to take calcium supplement because they have long term hypocalcemia. So, that's one pretty common reason for a low calcium level. Another is vitamin D deficiency. So, vitamin D is needed to absorb calcium from the gut. And if the patient has low vitamin D, then they're not going to have a great calcium level. That could be, obviously your patient who has limited sun exposure, maybe living somewhere in a northern climate where the sun is just not out very much in the winter time. But, globally across, any location, malabsorption would be another really good reason for this to occur. People who maybe are malnourished. And also older adults. So, vitamin D deficiency. Another pretty common reason is kidney disease. So, when the kidneys aren't working well, they're not activating vitamin D effectively, which, as you just heard, vitamin D and calcium kind of have a very simpatico relationship. But the kidneys, when they're not functioning properly, electrolytes just across the board are going to be out of whack. So, when you have your patient with renal disease, they're always getting a BMP, a basic metabolic panel, maybe a complete metabolic panel every day, because we really want to see what their electrolytes are doing. And remember that calcium and phosphorus have an inverse relationship. So when calcium is low, phosphorus is high. So you'll also often see that high phos level in your renal disease, especially your end stage renal disease patients. So, another reason for a low calcium level is the patient has low albumin. This is basically kind of like a pseudo hypocalcemia. They're not really low on calcium, but in order to figure that out, you have to do a little bit of math or get what's called an ionized calcium off of an ABG. So, the reason for this is that calcium binds up with albumin. And if the patient has low albumin, then the total calcium can look low when it really isn't. So when you see that combination of low albumin and low calcium, you need to ask yourself, is this true hypocalcemia or is this because of low albumin? So again, just to explain that a little bit, about half of the calcium in your body is bound to proteins. And when it's bound up, it's not really doing anything for us physiologically. It's hanging around, it's not really doing anything. The other half is that unbound or free calcium or ionized calcium. So, just to make it more confusing, you could hear it called any one of those things: ionized calcium, free calcium, or unbound calcium. Basically, think of it as, being single and ready to mingle. Okay. It's out there, it's free and available, it can do some stuff for us. So, that calcium is binding up to proteins. Really common protein is albumin. So if the albumin is low, maybe the patient has some malnourishment going on, then the amount of calcium bound to it is also low. And this shows up as a low calcium on that basic metabolic panel. So you got to get your labs back and kind of evaluate what's going on with your patient. If the albumin is also low, we're going to do something called correcting the calcium. And it's a simple little math. We take the total calcium plus 0.8, which is multiplied by 4 minus that albumin level. And I don't expect you to remember this. I just wanted you to see that it's not a terrifying equation. You can also probably go on to what is that website? MedCalc, and put the numbers in there and use one of the med calculators. And so then you get your result. That is your corrected calcium. And then you can really see, okay, is it truly low or is it just low because the patient has low albumin? So that one does require a little bit of extra clinical judgment and clinical reasoning. Another common reason for low calcium levels are medications. So, some common ones are diuretics. Diuretics just make you pee, and sometimes you just pee out electrolytes. Bisphosphonates, which are medications used to ironically treat osteoporosis, but they can cause hypocalcemia. And basically, they do this by inhibiting bone breakdown, which is good because if we have osteoporosis, we don't want the bones to break down anymore. And so if we are inhibiting bone breakdown, we are reducing calcium release. So the calcium in the serum is going to be lower. Okay. And then anticonvulsants can cause it and certain chemo drugs. There's probably others, but these are some common ones that you'll see. Another reason for hypocalcemia that we definitely don't want to forget about is acute illness and some pretty significant illnesses like sepsis, like pancreatitis. A low calcium level in pancreatitis is associated with higher mortality. So if you see that with your patient's in for some pretty intense treatment and maybe a rough time. And then also blood transfusions. If they've had several or massive blood transfusion, the citrate in that packaged blood will bind up calcium, and so they could become hypocalcemic. So you're watching your patient for signs of hypocalcemia, perioral numbness and tingling, very common, muscle cramps, tetany. You could see a prolonged QT interval. You could see seizures, dysrhythmias, all kinds of scary stuff. So if your patient has hypocalcemia and they are displaying symptoms, we need to hop on this very quickly, and we treat it with calcium replacement. So symptomatic hypocalcemia in the clinical setting, probably going to get IV calcium. There's two forms, calcium gluconate and calcium chloride. Depending on how severe it is, calcium chloride is typically what is used when they are in extreme danger. Calcium gluconate apparently is a little safer to give. You do need to give both of them slowly. I believe in the ICU, when I gave this medication all the time, I was giving it over like 10 minutes. So you're not pushing it. It's not like a fast IV push, not even really a slow IV push, like 10 minutes or so to get that medication in. And then that asymptomatic hypocalcemic patient, they're going to get oral replacement, calcium carbonate tablets, super common, giving those to patients to get their calcium levels into balance. So that is your quick overview for quite a few different reasons why your patient may have a low calcium level. So when you see that on your patient's labs, you're taking care of a patient, maybe you're a student and you are writing up a care plan for a patient, connect the dots. Like, why do they have this low calcium level? Go back and look at everything else that's going on. Do they have an underlying condition? Are they taking one of those medications? Have they had thyroid surgery in the past? Like, trying to figure out what is causing it will really help you understand the big picture and how everything is connected. I hope this quick mini episode helped you, and I'll see you soon. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Monster Energy. Everybody knows White Monster Zero Ultra. That's the OG. It kicked off this whole zero sugar energy drink thing. But Ultra is a whole lineup now. You've got Strawberry Dreams, Blue Hawaiian, Sunrise, and Vice Guava. And they all bring the Monster Energy punch. So if you've been living in the white can, branch out. Ultra's got a flavor for every vibe. And every single one is zero sugar. Tap the banner to learn more.